السلام ورحمة الله وبركاته. Thank you for all. My pleasure to introduce Dr. Firas Al-Jamili. He's consultant gastroenterology. He will talk about how to approach with the patient with a high liver enzyme. Mike is yours, Dr. Firas.
وعليكم السلام ورحمة الله وبركاته. أهلا وسهلا دكتور محمد. السلام عليكم everyone. I'm Dr. Firas Al-Jamili, gastroenterologist. Today I'll be presenting an approach proposal on deranged liver function tests. So as an introduction, the abnormal liver enzymes are one of the most common reasons for referrals in the internal medicine or GI practice. The key objectives is to differentiate between liver injury tests and true liver function tests, and evaluate the patterns of enzyme abnormality to identify hepatocellular, cholestatic, or mixed causes, and determine the common versus rare causes of abnormal liver enzymes, and to know when to refer patients for further evaluation and liver biopsy. So the liver injury tests reflect damage to the hepatocyte and bile ducts. Examples include ALT, AST, alkaline phosphatase, and GGT. The liver function tests, which measures the function of the liver, synthetic function of the liver mainly, includes albumin. And albumin, just to note that albumin half-life is around 20 days. BT and INR, which depends on factor 7. Factor 7 half-life is around 8 hours. And bilirubin. Bilirubin, we measure the serum bilirubin, both direct and indirect, to measure the function of the liver in the conjugation and the excretion of bile in the biliary system. This requires ATP and a healthy hepatocyte. So as I mentioned before, we mentioned that the half-life of factor 7 is around 8 hours. In cases of fulminant liver failure, one of the earliest signs you will see is encephalopathy, and one of the earliest labs that you will see is a rapidly increasing INR. So the main function of the liver includes the metabolism of proteins, carbohydrates, fats, and vitamins, storage of glycogen, vitamins and minerals, detoxification and inactivation of endogenous substances like bilirubin, and exogenous substances, and secretion of bile, and the synthesis of coagulation factors. So this table summarizes the main things that we see during liver testing, including serum albumin and INR that measures the synthetic function of the liver, serum bilirubin total, both indirect and indirect, which measures the hepatic anion transport. It's important to note that hepatic anion transport is ATP dependent, so it requires a healthy hepatocyte and an ATP for the excretion of bile. The bilirubin conjugation is indirectly dependent on ATP and the healthy hepatocyte. So both bilirubin conjugation and excretion requires ATP and a healthy hepatocyte. That is why maybe some of you have seen patients with acute liver failure or fulminant liver failure who have increase in both direct and indirect bilirubin. And we measure the enzyme levels, including ALT, AST, which measures the hepatocellular integrity, alkaline phosphatase, and GGT, which measures the presence of cholestasis. This is another table summarizes the patterns of liver injury. So mainly we have hepatocellular, cholestatic, mixed, and isolated hyperbilirubinemia. In the hepatocellular pattern, mainly we have certain differential diagnoses, most commonly viral hepatitis, non-alcoholic fatty liver disease, drug-induced liver injury, and Wilson disease. ALT is more specific to the liver than AST, which can come from other myocytes, and including musculoskeletal muscle and heart. The ALT is more specific. So whenever you see an ALT more than the AST, you think more about liver injury. There was an observation that elevations in AST more than ALT comes with alcohol-related liver disease. In cholestatic pattern, you will note a striking elevation in alkaline phosphatase and GGT compared with ALT and AST. The bile duct, the differential diagnosis includes bile duct obstruction and biliary disease, biliary system disease, like primary sclerosing cholangitis or primary biliary cholangitis. usually we confirm with the GGT and we proceed with the transabdominal ultrasound to rule out biliary obstruction. Mixed patterns, you will notice sometimes you will have both elevations in ALT, AST, alkaline phosphatase, and GGT. And you cannot identify any specific pattern of the liver injury. This can come with the drug-induced liver injury and infiltrative liver diseases. The isolated hyperbilirubinemia includes isolated elevation in bilirubin. This can come from Gilbert syndrome and hemolysis. So if someone asks, how can I identify which pattern of liver injury there is, I recommend that you use the R ratio or R factor. It is a very simple equation. Basically, you take the ALT divided by the upper limit of normal of ALT. This is divided by alkaline phosphatase divided by upper limit of normal of alkaline phosphatase. This way, you will have a ratio. The ratio, if it is more than 5, this goes with the hepatocellular pattern of liver injury. If it is less than 2, this goes with the cholestatic pattern of liver injury, deranged liver function test. And if it is between 2 and 5, you think about mixed pattern. If every pattern of liver injury carries a certain differential diagnosis. Is it clear so far? Can I proceed, or you have any question about this slide? Okay, so the patterns of liver injury, I hope it is clear by now. So whenever you have a hepatocellular pattern of liver injury, you think about a certain differential diagnosis that we discussed earlier. Cholestatic, you will have a certain differential diagnosis, and mixed patterns, you will have certain differential diagnosis. You think more about drug-induced liver injury. The things that to note, if you see an elevation of AST more than ALT, you think about alcoholic liver disease. AST ratio more than AST more than ALT, you think about as well liver combining liver cirrhosis. There is a ratio that we can use that is alkaline phosphatase divided by the upper limit of normal of alkaline phosphatase divided by total bilirubin divided by the upper limit of normal of total bilirubin. يعني basically هذه تبي تطلع لك ratio of alkaline phosphatase compared to the bilirubin. إذا كان أقل من 2, if it is less than 2, you think about Wilson's disease. The trick هنا in the questions, the trick always you will be presented with the patient expressing signs and symptoms of Wilson's disease. Usually in the question they will give you normal alkaline phosphatase or below normal alkaline phosphatase. Always, if you are faced with this question, you think about Wilson's disease, especially if there is a neuropsychiatric manifestations as well, accompanying the acute liver injury. If the ALT is more than AST, think about viral hepatitis, NAFLD, and drug toxicity. If the AST more than ALT, you think about alcoholic liver disease, ischemic hepatitis. We will talk about severe elevations in the next few slides. The cholestatic pattern, you have elevation in alkaline phosphatase and GGT. Extrahepatic causes includes gallstones and malignancy, especially pancreatic cancer or cholangiocarcinoma, anything that obstructs the biliary system. The intrahepatic causes of the elevation cholestatic liver injury includes primary biliary cholangitis and primary sclerosing cholangitis, infiltrative liver diseases, and medications. Certain medications can cause cholestatic liver derangement of liver function tests. So now I'll talk about the Club of 1000. This is a terminology that we commonly use as gastroenterologists. We have certain differential. Whenever you have ALT, AST elevations more than 1000, you think about certain differential diagnosis. You can memorize it with the mnemonic VIMA, WA. VIMA includes viral hepatitis, ischemic hepatopathy, medications like acetaminophen or toxins like mushroom poisoning, and autoimmune hepatitis. Rare causes includes Wilson's disease and acute biliary obstruction. Acute biliary obstruction can cause, in certain, in few occasions, it can cause elevations in liver enzymes more than 1000. So the key questions, the time frame, is it acute or chronic? Symptoms like fatigue, jaundice, pruritus, right upper quadrant pain, and weight loss. Pruritus that accompanies cholestatic liver disease, mainly because of the retention of the bile salts. This symptom is very well correlated with the primary biliary cholangitis, and the reason for this pruritus is the accumulation of the bile acids in the subcutaneous tissue. Risk factors includes alcohol use, medications, supplements, IV drug use, tattoos, unprotected sex, etc. Family history of liver disease or autoimmune conditions like autoimmune hepatitis, like Wilson's disease, like alpha-1 antitrypsin deficiency, etc. So this another table. I think it is repeated. So we covered this slide already. So the diagnostic approach, first you define the pattern of the derangement of liver function tests. You go with the R ratio. I recommend that you routinely use the R ratio whenever you are faced with derangement of liver function tests. This will make your life easier, and it will make the approach much simpler and your decision more clear and more confident. So you go with the R ratio. If the R ratio is more than 5, it is hepatocellular. If it is less than 2, it is cholestatic. If it is between 2 and 5, you think about mixed derangement of liver function tests. You go with investigations panel if it is hepatocellular with the hepatitis A, B, and C, autoimmune markers for autoimmune hepatitis, ANA, asthma, and for primary biliary cholangitis, if it is cholestatic pattern, you do the anti-mitochondrial antibody. You do the metabolic workup for ceruloplasmin for Wilson's, iron studies for hemochromatosis, especially transferrin saturation, alpha-1 antitrypsin for alpha-1 antitrypsin deficiency. Imaging, we go first with ultrasound, transabdominal ultrasound, and in certain situations, whenever the need arises, we go with the CT and MRI. In cases of severe elevations, you screen for drug toxicity, like acetaminophen, and you do the viral hepatitis screen, and consider ischemic injury, especially if there is a history suggestive of hypotension, like patient who had cardiac arrest, who had CPR, patients who had hypotension during surgery, and then he developed high liver enzymes, etc. So what is the role of liver biopsy? Usually liver biopsy is the last resort. آخر خيار. زين. Whenever you are presented with a question, when the extensive workup done for the patient, almost all the labs and radiologic investigations were done, and it was inconclusive and unrevealing for the diagnosis, you think about liver biopsy. Okay, so you do it whenever it is unclear for non-invasive testing, and you assess the disease severity. You assess the fibrosis and cirrhosis and presence or absence of active inflammation, and what type of inflammation is there. The types of liver biopsy includes percutaneous. This is standard approach, rarely done nowadays. Transjugular, done by interventional radiologists. This is more commonly done nowadays. You choose with the transjugular route whenever you are faced with patients who have ascites or coagulopathy. Complications are rare and include bleeding, around 1%, and life-threatening bleeding, 1 in 1,000 cases, or infection. The non-hepatic causes of elevated liver enzymes includes muscle injury, as we mentioned earlier. You confirm this with doing CK levels and adulase. Thyroid disorders like hypo or hyperthyroidism, celiac disease, mild elevations in ALT/AST have been seen with celiac disease, and it is one of the indications. If you go back to the guidelines for celiac disease, one of the indications for celiac disease serology is unexplained elevations in ALT/AST. Whenever you are faced with elevations in ALT/AST, which is not explained with initial investigations, including viral hepatitis and imaging, you think about celiac disease, okay? Adrenal insufficiency, you check AM cortisol, and medications including statins, antibiotics, and herbal supplements. A lot of herbs cause elevations in liver enzymes, especially يعني شواهي الأعشاب، شاي المرامية وشواهي الأعشاب بشكل عام، الشاي الصيني اللي كانوا يستخدموه للتخسيس. Many herbal teas are يعني attributed are blamed to cause acute elevations in liver enzymes. Another herbs includes مرة أنا ما أتوقع أن بيجيكم عليها أسئلة. لكن mainly herbs يعني a lot of herbs can cause elevations in liver enzymes. So now we'll go to the questions. Do you have any questions before we proceed with the Q&A questions? The question, 48-year-old woman evaluated at follow-up appointment with elevated liver chemistry tests over the preceding 6 months. She reports no symptoms. She has type 2 diabetes, hypertension. Her family history is unremarkable, and she drinks 2 glasses of wine 1 to 2 times per month. Her medications include metformin, lisinopril. Vital signs are normal. She is class 1 obese, no stigmata of chronic liver disease, or abdominal distension. There is no lower limb edema. Liver enzymes including يعني shows mild elevations in the AST/ALT. Alkaline phosphatase within normal. Anti-smooth muscle antibody is mildly elevated. So results from other studies, including viral hepatitis serology, is unremarkable. Iron saturation, alpha-1 antitrypsin studies are unremarkable. TTG IgA is unremarkable. AMA is unremarkable. Total IgG is unremarkable. Ultrasound and liver of the liver shows hyperechoic liver and enlarged. So what is which of the following is the most likely diagnosis? Can we put the poll, please? answer is the primary sclerosing cholangitis. So let's dissect these answers. So we have basically احنا طبعا عندنا hepatocellular pattern. If you go with the R ratio, this is hepatocellular pattern of acute liver injury or chronic. It could be chronic. عندنا two diseases that present with cholestatic pattern of derangement of liver function test. الكوليستاتيك diseases اللي عندنا هنا اللي هي البرايمري biliary cholangitis وعندنا البرايمري سكلوروزنج cholangitis. So we can exclude these two answers. Autoimmune hepatitis ما عندنا history suggestive of autoimmune hepatitis. The patient has negative ANA and asthma. So it's less likely to be autoimmune hepatitis. So the most likely answer here is non-alcoholic fatty liver disease for many reasons. First, the patient has metabolic syndrome. Okay, she's obese and she has a history suggestive she has type 2 diabetes. So this and she has an ultrasound finding of hyperechoic liver. This goes with non-alcoholic fatty liver disease. So someone asked about the autoantibodies. Between 20 to 30% of patients with non-alcoholic fatty liver disease exhibit low titers of autoantibodies. Okay, so low titer of antibody does not indicate that the patient has primary biliary cholangitis. Okay, is it clear? Do you have any question? If someone has any question, he can raise his hand. We will be happy to answer. Okay, so we'll proceed with the next question. 32-year-old woman is evaluated for 6 months history of loose stools and bloating. Her medical history is otherwise unremarkable. Her brother has type 1 diabetes and her mother has autoimmune thyroid disease. She reports no other symptoms and takes no medications. Physical examination, vital signs were within normal. BMI is 19. Hemoglobin is normal. ALT is 60. AST is 42. Total bilirubin is 15.4 within normal. Ferritin is 6 nanograms per ml. Which of the following is the most appropriate test to perform next? Anti-gliadin IgA antibody, anti-saccharomyces cerevisiae IgA antibodies, anti-smooth muscle antibody, or anti-tissue transglutaminase IgA antibody. So can we put a poll, please? So basically, young female with family with chronic diarrhea and bloating, with family history strongly positive for autoimmune diseases, presented with elevations in liver enzymes. So what should we do next? Can we have Paul Mustafa? Okay. So most of you chosen the correct answer. 87% are going with anti-tissue transglutaminase antibodies. The question was more straightforward than this, and I made it more big. In the question stem, the patient was having iron deficiency anemia. I removed this because 15% of celiac disease patients, they have iron deficiency anemia. عندنا 85% of patients with celiac disease, they do not present with iron deficiency anemia. So you might be faced with this question. So one of the patient has more than one indications to test for celiac disease. The correct answer is the anti-tissue transglutaminase IgA antibodies. So the first test is to do anti-tissue transglutaminase IgA antibody because of its high sensitivity, and it's recommended as a first-line investigation for patients suspected to have celiac disease. So this is the correct answer. Next question, a 44-year-old man is evaluated after routine yearly follow-up for ulcerative colitis. His lab showed elevations in liver enzymes. He was diagnosed with ulcerative colitis 5 years ago. He reports that he passes solid formed stool every 1 to 2 days without abdominal pain. His only medications is mesalamine. So he's a patient, a middle-aged patient with diagnosed with ulcerative colitis who appears to be in clinical remission. Okay, physical examination shows overweight patients. He has hepatosplenomegaly and hepatosplenomegaly and palmarythema. Okay, liver enzyme shows alkaline phosphatase of 4.12, ALT of 78, AST is 62, total bilirubin is 34, mildly elevated, direct bilirubin is 26. So it's mainly direct hyperbilirubinemia. Okay, can you go with the R ratio? Can someone calculate the R ratio and tell us what is the R ratio in this patient? So basically for the R ratio, you do the ALT اللي هي 78 قسمها على upper limit of normal of ALT which is 32 يطلع لك تقريبا 2. وعندنا الالكالين فوسفاتيز هذا المقام طبعا اللي هو ال ALT divided by the upper limit of normal of ALT اللي هو البسط عفوا. المقام يكون الالكالين فوسفاتيز divided by the upper limit of normal of alkaline phosphatase اللي هو 120. فنقسم 400 على 120 يطلع لنا 3.5 تقريبا. اوكي سو يعني الريشيو يعني تقريبا راح تكون 2 على 3.5. الريشيو تبي تكون اقل من 2 فهذه وش راح تكون؟ Can someone answer please in the comments? So our ratio is less than 2. So what is this? يعني what should it be? يعني which pattern of liver injury we have? Cholestatic, yes, excellent. So it is cholestatic, okay? So complete blood count, serum creatinine level are normal, antimitochondrial antibodies are negative, MRCB shows hepatomegaly but is otherwise normal. Liver biopsy is pending. Which of the following is the most likely diagnosis? Is it antimitochondrial antibody negative primary biliary cholangitis, drug-induced liver injury, NAFLD, or primary sclerosing cholangitis? So can we put a poll? Can we have a poll, Mustafa? البول result عفوا. Okay, so a majority are going with primary sclerosing cholangitis. This is a straightforward question about a patient with primary sclerosing cholangitis. يعني طبعا I think all or most of you are familiar that there is a strong association between inflammatory bowel disease and primary sclerosing cholangitis. There is no correlation regarding the activity of inflammatory bowel disease والactivity of primary sclerosing cholangitis. So يعني around 75% of primary sclerosing cholangitis patients have ulcerative colitis, and 5 to 10% they have Crohn's disease. 5% of UC patients they have BSC, and 2% of Crohn's disease patients have PSC. طيب let's say now the patient طبعا ممكن يجيكم سؤال، انا مر علي سؤال قبل انه يجيب لك الستم حق السؤال يقول لك مريض واحد ينج ميل مثلا وتشخص هيز asymptomatic doing ultrasound for any other reason، وبعدين طلع عنده beaded biliary system، يعني في عنده strictures going with primary sclerosing cholangitis. So what is the next step in this situation؟ لما تسوي diagnosis of primary sclerosing cholangitis what should you do next؟ Can someone answer in the comment section؟ يعني نبي نقلب السؤال الحين، احنا جبنا واحد عنده inflammatory bowel disease نبي نجيب الطريقه الثانيه، واحد عنده primary sclerosing cholangitis what should you do next؟ Colonoscopy, yes. These patients are they have a high risk of colorectal cancer. هذول الجروب, this group of patients they are at high risk of developing colorectal cancer, so you have to do colonoscopy now. بيجيك الخيار يقول لك colonoscopy now, you choose this answer, okay? So whenever you diagnose with primary sclerosing cholangitis you have to do colonoscopy urgent يعني first available and routine، يعني you do it on routine basis. As a patient يصير يعني من الافريج ريسك جروب مثلا او اللو ريسك جروب يتحول للهاي ريسك جروب of developing colorectal cancer. Okay, so the next question, a 26-year-old woman is evaluated for new onset of jaundice. She reports no fever, abdominal pain. Her medical history is unremarkable and she takes no medication. On physical examination, vital signs were within normal. Scleral icterus and psychomotor slowing are noted. Hemoglobin is low, reticulocyte count is high, 8%. Alkaline phosphatase is 26, ALT is 78, AST is 158, total bilirubin is 109, and direct bilirubin is 45. Testing for hepatitis A, B, and C viral infection is negative for acute infection. Abdominal ultrasound, the liver is small and nodular, going with cirrhosis يعني. Splenomegaly is noted, mostly because of the portal hypertension. Which of the following is the most appropriate test to perform next? Can we put a poll, Mustafa? Antimitochondrial antibody test, viral hepatitis B DNA, serum ceruloplasmin, or transferrin saturation? Okay, can we have a poll, Mustafa? Okay, so هنا في اختلاف يعني 44% going with ceruloplasmin, 33% going with transferrin saturation, 22% are going with antimitochondrial antibody. اللي هو طبعا هنا نفس الطريقه نفس الشيء، انا ابغاكم تمشون على الار ريشيو، اوكي؟ لو نحسب الار ريشيو هنا بتطلع لي more than 5، اوكي؟ So we can exclude primary biliary cholangitis. معناته الانتيميتوكوندريال antibody is not needed. We shouldn't do it by now. Okay, so we have a hepatocellular pattern of liver injury. Okay, if you go the R ratio it will become more than 5. Okay, this is one thing. Another thing, هذا a young adult 26-year-old عفوا she's a young adult عندها psychomotor، عندها neurological symptoms، اوكي؟ وعندها chronic liver disease، اوكي؟ عندها hemolysis، واضح انه عندها hemolysis لان reticulocyte count is 8%، اوكي؟ So what should we think about here in this situation? We think about Wilson. Okay, Wilson disease, they present with neuropsychiatric manifestations. Usually neuropsychiatric manifestations تطلع بالليت late adolescence، وبعدين الهيباتيك ويلسون يجينا على العمر هذا تقريبا على نهايه العشرينات. اوكي، هذه one thing. عشان كذا احنا دائما one of the diagnostic approaches we do the slit lamp for KF rings, Kaiser Fletcher rings. Okay, so this is a Wilson, typical Wilson case, patient with chronic liver disease, hepatocellular pattern of derangement of liver enzymes, hemolysis hemolytic anemia. اوكي. وعندنا اللي هو neurological symptoms. اوكي. So this is a typical Wilson's case. اوكي. Is it clear? اوكي. ممتاز. تمام. So هنا الويلسون although it is rare but they like to ask about it in examinations. Okay. So I would recommend that you read about Wilson. الويلسون يحبون يجيبون عليها اسئله ليش؟ لانه موضوع كبير. توبك لو تلاحظون عندنا الهيباتيك ويلسون النيورو ويلسون والمانجمنت فيه كلام كثير. فدائما المواضيع هذه اللي فيها فلكسبيتي يعني يقدرون يجيبون عليها اسئله يعني باي طريقه يحبون يجيبونها مع انها رير لكن this is how examination يعني works. So دائما المواضيع الكبيره زي السيليك في ديسكشن كثير يحبون يجيبون عليها اسئله. ويلسون في ديسكشن كثير يحبون يجيبون عليها اسئله. فدائما انتم for examination purposes you should be familiar with these topics. Okay. طيب احنا ذكرنا السيروبلازم هنا. تمام. طيب next question. A 32-year-old man is evaluated for 1 week history of jaundice and pruritus. 1 month earlier, he completed treatment for sinusitis with augmentin. His sinusitis symptoms resolved with therapy. On physical examinations, vital signs are within normal. He's overweight. Jaundice is noted. Excoriations seen on the extremities. The abdomen examination is normal. That shows INR is normal. Albumin is 38, mildly elevated. Alkaline phosphatase 580. ALT is 42. AST is 38. Total bilirubin is 147. Hepatitis A, B, and C Epstein-Barr virus studies were unremarkable. Testing for ANA asthma is negative. Serology is normal. Result of abdominal ultrasound is normal. There is no evidence of biliary dilatation, gallstone, hepatic or parenchymal abnormalities. Okay. طيب let's go with the R ratio. So what is the R ratio هنا؟ ال R ratio كم تبي تصير أقل من 2 صح ولا لا؟ لأنه عندنا البسط اللي هو ال ALT is very low. يعني compared مع elevation of the alkaline phosphatase. So if you calculate it, it will become less than 2. So this is cholestatic liver injury, cholestatic pattern of derangement of LFTs. Okay. So you think about cholestatic liver disease. Okay. طيب the next question, the question is which of the following is the most appropriate next step in the management? So can we have a poll? So can we have a results of the poll? اوكي. طيب هنا طبعا الماجوريتي ار جوينج وذ اي ار سي بي الليفر بايبسي. طبعا الماجوريتي اللي نتكلم عن 55%. some recommended 27% recommended prednisone and 9% recommended for continued observation. So this is a case of drug-induced liver injury, DILI. Okay, drug-induced liver injury mainly caused by the augmentin. Augmentin is very well known to cause cholestatic liver disease. Okay, the patient. Here, if we go back to the labs, the synthetic function of the liver is maintained. Okay, the INR is 1. The patient does not have acute liver failure. Okay, so the reasonable thing to do is to do continued observation and stop the offending medication. مثلا لو كان المريض ياخذ herbal intake, herbs يعني medicinal herbs, you ask him to stop. يعني you have to tell him to stop. يعني counsel the patient. If he is taking augmentin, for example, it is stopped already from the scenario. If he takes whatever the medication that caused this derangement in LFTs, he has to stop, and you continue observing this patient. Okay, so the correct answer is to continue observation. So the patients will preserve the liver function. Drug-induced liver injury should be managed with discontinuation of the offending medication or agent and observation until resolution of symptoms. Next question. 40-year-old woman with no significant comorbidities presents with jaundice, pale stool, dark urine, and she reports taking paracetamol occasionally for headaches. She also takes nifedipine for mild hypertension and oral contraceptive pills for contraception. She's thiazide diuretics for fluid retention. On physical examination, she has scleral icterus, and her liver is non-tender on palpation. Laboratory showing elevations in total bilirubin. ALT is mildly elevated. AST is mildly elevated. Alkaline phosphatase is significantly elevated. GGT is elevated. Abdominal ultrasound shows dilated intrahepatic bile ducts with no visible gallstones or masses. Okay, so which of the following medications is the most likely cause of this patient? So we have يعني suggestive scenario suggestive of cholestatic liver disease. Okay, يعني من الstem of the question. So what is the likely cause of her cholestatic liver disease or cholestatic pattern of derangement of liver function test? So is it thiazide, oral contraceptive pills, nifedipine, or paracetamol? Can we have a poll, Mustafa? Okay. So what is the culprit medication here? Can you answer the question? Can we have the result, Mustafa? Okay, so here majority are answered correctly, 58% going with oral contraceptive pills. Paracetamol, usually they will present with acute hepatocellular pattern, plus minus acute liver failure. thiazide is less likely to cause this presentation. So the cholestatic DLE is characterized by elevations in alkaline phosphatase and GGT. Common drugs causing cholestasis includes oral contraceptive pills, anabolic steroids, augmentin, and chlorpromazine. Oral contraceptive pills can cause hormonal cholestasis, particularly in predisposed individuals with genetic factors affecting the bile salt transport. Presentations include jaundice, dark urine, and light stool, and pruritus. طبعا هنا البكتشر هذه اللي تعطينا فكره عن ال R ratio as we mentioned before. اتوقع انه now I think you are familiar with. So differentiating طبعا you go with the R ratio to differentiate between the pattern of liver injury. When you manage the cholestatic DLE, you discontinue the offending drug, monitor liver function tests for resolution, and consider also for symptomatic relief in severe cases, especially itching. So the correct answer is oral contraceptive pills. And this is my presentation. Thank you very much for interacting and attending this session. In case you have any question.